lady Chantel Thornton to our campfire chat this evening. Chantel is the most incredible, accomplished woman that you'll ever meet. She is an amazing breast surgeon. I credit her for saving my life and helping me get back on track and healthy, and it's 10 years since. So there's some testimony just in that fact that I'm still here and super healthy. And Chantel also has a young family, 2 gorgeous little children, and is super fit and healthy. So how she crams it all in, she can let us know. I've got no idea.
They actually were. Thornton actually fell off the ladder at school on Thursday and sustained a grade 3 fracture of his arm. So he went for emergency surgery on Thursday night. So, yeah.
Oh, you've had a time of it. My goodness. Well, a big welcome and thank you for joining us. We have some of our Camino women ladies here that would love to just hear about your life and how you think that women should stay healthy and to basically avoid becoming one of your patients is best idea really. And if they do, any tips for recovery and bouncing back after all those cancer things. So
yes. All right. Now, so I think first of all, I'd like to say that I guess breast cancer is the most common cancer diagnosed in women. In Victoria, the rate's about 1 in 7, so the rate is certainly skyrocketing on. But in saying that, we are more commonly diagnosing it, but we are less commonly dying from it. So women are likely to live a long time if they are diagnosed with breast cancer. So the first thing I would say is don't panic if you get diagnosed with breast cancer because it is likely that you will live a very long time. Now, obviously, people want to reduce their risk of getting breast cancer. And there's something that we are doing in the Western world that is increasing our risk, and we're not quite sure what that is at the current time. The main risk factors that we have are very commonly associated with other diseases, particularly heart disease. And more people in Australia die of heart disease than they do breast cancer. And so a lot of it's actually not rocket science. It's mainly what our grandparents taught us. But the most important things that you can do from a lifestyle perspective, and it seems like I'm probably speaking to the converted, are, diet, exercise, alcohol, cigarette smoking. And so what does the available evidence say? Well, what it says is that, you're female. You can't really change the fact that you're born female. But what you can do, I suppose, is try and from a young age, focus on lifestyle factors to try and improve your risk. So from a dietary perspective, the current evidence states that eating 5 vegetables a day and 2 fruit will reduce risk of breast cancer. And in women that have already been diagnosed with breast cancer, particularly postmenopausal women, there's good evidence to say that it will decrease the risk of recurrence. Exercise, keeping your body mass index in a healthy range is important. I sort of hesitate to say that because I think body mass index is actually very outdated technology, if you like, for managing people's weight. I mean, BMI was established many years ago. It doesn't take into consideration different cultures. It doesn't really assist us in making decisions much about weight in a patient. Like, I'm more concerned about how much someone can move rather than, is their body mass index 31 or 30, for example. So in saying that, the exercise that has been proven to decrease the risk of breast cancer is 240 minutes of exercise a week. Within that 240 minutes, you're looking at 150 minutes of aerobic work, so work where you're really pushing hard, finding it hard to speak, moving your body fast, and then 90 minutes of core strength work. And we're talking about weights, we're talking about Pilates, yoga, other things. And I think that will become more important as a generation for younger women, that they start early with that weight-bearing exercise. Traditionally, we've never discussed that in women in their sort of teens to 20 to 30-year age bracket. No one's ever spoken to women about getting their bone mineral density improved. But I think it will be important, and not just from a breast cancer perspective, but from our bone health because I think that the leading cause of death for women will be, osteoporosis or fractures in your 80s. You're getting a hip fracture, you're falling out of bed with a hip fracture, you're dying of those sort of things. And so I think it's time for women to focus on their health and bring it back to talking about things like bone health at a younger age bracket. It is quite hard, I think, to get in 240 minutes of exercise a week. And so any exercise that you can do, like walking to work, if you're driving to work, don't do it every day, or pull your car over earlier, walk, leave your car at another train station, things like that. Just trying to get exercise in your day. If you see stairs, and you feel confident on stairs, take the stairs. So I think that it is really, really important. We also know that women that are having chemotherapy, who are exercising while they're having their chemotherapy, for example, having a treadmill in the laboratory while they're getting chemo, we know that they are doing better. Their survival is better. So that's diet, exercise, alcohol. Best is 0. We know alcohol is a carcinogen. But if you can't have 0 and you enjoy it, less than 10 standard drinks in the 7 days of the week. And then cigarette smoking. Smoking increases the risk of every cancer, including breast cancer. And vaping is probably going to be about the same. And I think we're going to see a whole new sort of gamut of cancers coming. And they will be cancers of the throat, cancers of the mouth, a very different style in the next probably 10 to 15 years of cancers through vaping. So we've done diet, exercise, alcohol, cigarette smoking. And then I'm going to put stress in there. I don't know that there is a lot of hard evidence, but there certainly is a lot of evidence looking at the immune system when someone's being diagnosed with breast cancer. And so if you look, for example, at taking a stressed animal who's got a cancer, putting them on a beta blocker, harvesting the cancer, you can see that the survival of that animal is improved on the one that's had the beta blockers where their heart rate's been slowed down. And so to extrapolate, there have been human trials looking at making people feel calm in their environment when they're diagnosed. For women to look at their life and see, are there ways that I can change my life after such a significant diagnosis? Is there something in my life that's causing a problem for me, either inwardly or outwardly, that needs to be changed? And I don't have a lot of evidence, but I do see that there are many women in my practice where I think these women will come back to me in 1 or 2 years saying, I've made significant changes in my life. That boyfriend's gone, that, relative or that problem I had, that job I had, whatever it was, it's gone, and it's helped me. It's helped me recover. It's helped my immune system. So what I can say is keeping things as calm and as possible at diagnosis is really important. And that's the whole impetus for my rooms, in that I have my consulting rooms in a house that, I've had beautifully fitted out. I've got a gorgeous garden. I don't have any signs about cancer on my front door. I have a bright pink front door. Providing hope to the patient is really important. Then we're looking at, there's sort of the lifestyle related things you can do. Then there's things like, having babies early, breastfeeding those babies. You've got to have had babies before the age of 30. You've got to have breastfed them for more than 6 months. It's not a lot of people in our community are doing that. Things like, does IVF increase the risk of breast cancer? No, the new IVF drugs do not increase the risk of breast cancer. Obviously people having IVF are often older. They often haven't had children, so they're already at slightly higher risk. Then we look at family history. Knowing your family history is important. Family history on the maternal side, family history on the paternal side, knowing siblings of the grandparents, knowing your mum and dad's aunts and uncles, knowing your cousins' history, knowing your brothers and sisters' history. I think it's important. Some families talk and some don't. Some don't realise it's on the paternal side. Knowing if you're from where you're from, like if you have Ashkenazi Jewish background, is there an increased risk that you might carry a mutation? It's very important. And then breast density, it's become obviously very prominent in the lay media recently. Knowing your breasts, and it's something in America that, for the last 20 years, women have known their breast density. So how dense am I? Are my breasts very, very dense in that I'm being lulled into false insecurity? Someone's doing a mammogram on me and they're saying everything's fine, but actually all they're seeing is complete whiteout. Will a cancer potentially be hiding in my breast that I can't see? Do I need to have an ultrasound? Do I need to have an MRI? So really tailoring your breast screening to your breast density, knowing that breast density is an independent risk factor for breast cancer, not just merely due to the camouflage effect. And there's lots of, again, animal models looking at dense breasts. It's not just due to the fact that you've got more ducts and lobules. There's something at the molecular level that might be causing breast cancer. So I think there would be the first things that I would say, knowing your risk factors and then being able to calculate it. There's a lot of really great sites like the CAN risk assessment. If you put, risk calculator in, Cancer Australia has a site. There are a lot of sites online that are actually pretty good that will give you a percentage of, what your lifetime risk of breast cancer is, what your risk might be in the next 10 years. And then if your risk is more than sort of 10%, you might decide that you'll go and see a breast physician or a breast surgeon. You might decide that you might speak to a geneticist if you look at your family history and think this could be a problem. The other thing about family history I should mention is that number of relatives is important. So if you are a woman that only has a brother and your mum and dad will say only children, it's quite hard for you to know if your risk is significant because you haven't got multiple members of the family to compare that to. And then, as I said, getting your screening done. Currently, I recommend if women are over the age of 40 that they do a mammogram and an ultrasound. I should mention that HRT is not a significant risk factor for breast cancer, particularly if you're taking the bioidentical HRT. If you're using an estrogen-only HRT and, for example, you've had a hysterectomy or you've got a Mirena and you're just taking estrogen only, it does not seem to impact on your HRT. If you're taking a bioidentical HRT with estrogen and progesterone, there does not appear to be a significant increased risk in breast cancer if you're taking that HRT for less than 5 years. And I think specifically if you're doing, a lot of exercise, you're not eating a highly saturated fat diet, you're not smoking, you're not taking a lot of alcohol, you can circumnavigate your risk. So I wouldn't be too concerned if you're taking HRT. A lot of people do worry about that. But I would mandate to patients and doctors, say to them, look, if I'm taking HRT, if I'm going to start on HRT, could I have baseline imaging? I do think that is important, that patients do consider having baseline imaging before they start on HRT. Now, the other things we should talk about is atypical cells. So if patients have previously had a history of atypical cells on biopsy, if they've previously had lobular carcinoma in situ, or they've previously had a breast cancer many years ago, it still puts them at higher risk than the population risk. With the family history, knowing if there's a male breast cancer, knowing if there's bilateral breast cancer, knowing if there's a young age at which breast cancer occurred, so less than 40, or multiple breast cancers in the family, important. Women that have had radiation to their chest or neck, say they've had a Hodgkin's lymphoma or something that's required radiation, those patients are at increased risk of getting a breast cancer and having an early period or a late menopause, and primarily age. So the older we are, the more likely we are to get any cancer. Your DNA does not replicate as fast. Doesn't repair as fast when you're older. And so even though Breast Screen actively advertises for patients to come until they're 74, if you're over the age of 74, and you're independent and healthy, you should self-remind and self-refer, because the older you are, the more likely you are to get any breast cancer. If people would like to stop me and ask questions, I'm very welcome for you to interrupt me as well. What about presenting symptoms? Well, by and large, 70% of breast cancers are presenting with asymptomatic. They can also be a lump or thickening in the breast. It doesn't have to be the age-old little, nodule in the breast that people find. It can be a change in size, contour, shape of the breast, tethering of the skin, rash of the nipple, lumps in the armpit. There are a variety of things that can present, but normally it is a screen detection, and most of those will present with absolutely no symptoms. I would encourage people, if they do have a symptom, that they do seek attention from the doctor, even if your imaging is normal. So even if you've got a normal mammogram, a normal ultrasound, if you've got a symptom, get seen by a doctor, because you can have completely normal imaging and still have breast cancer. And this is quite common in lobular breast cancer, where you do not see it on mammogram, you do not see it on ultrasound, and you sometimes also don't see it on MRI. And sometimes it is just a little thickening in the breast that you see. So what are you going to do if you're diagnosed? Firstly, don't panic. You're very likely to live a very long time. Select your team wisely. Try and choose someone in a similar age bracket or someone slightly younger, so that they are with you for the journey. Take a friend or someone very good at note-taking, or a partner with you. Ask lots of questions and keep your life absolutely as normal as possible. If you're young, there are specific criteria that you need to address, particularly fertility, as if you are in your 30s or late 30s and you've not had children, it's likely that you'll need chemotherapy. We know stage for stage age is important, so less than 40 do worse than women over 40, less than 35 do worse than women over 35. And so in that circumstance, it is likely that you will need to have chemotherapy, and therefore in that circumstance, you want to consider doing a fertility consult to see if you can save any eggs before proceeding to chemotherapy, which might make you infertile. And by and large now, it depends on your tumour type as to what pathway you will take. If you have a triple negative breast cancer or a HER2 positive breast cancer, you may be offered some chemotherapy first. We call that neoadjuvant chemotherapy, and the purpose is to shrink the tumour down, number one, and also to allow time for you to get genetic testing, and also to see, was my tumour treated by chemotherapy? Was I able to ensure that the chemotherapy killed my cancer? So when you come to take out the cancer, then you can see, did the cancer dissolve away, or do I need extra treatment? So if your cancer is estrogen receptor positive, progesterone receptor positive, smaller node negative, you're likely to go down the pathway of breast surgery up front. Normally in my patients, I do offer them genetic testing. I also offer them turn on reactions. Oh, okay. Should I do that? Do I have to do that? Turn on reactions? No?
No, I don't know why your camera's gone off.
Okay. Okay, just press that off. Okay, good.
Oh, yeah.
I do offer my patients genetic testing. The government is now rebating for ER/PR positive breast cancers to have gene testing. I also offer MRI in my patients. In most cancer patients now, MRI is rebatable. In women that have ever had breast cancer before the age of 50, MRI is now rebatable. So we offer that for our patients. We usually offer, as I said, a PET scan as well to stage the patient before going to theatre, and blood investigations. We offer breast reconstruction with our patients that are oncologically able to have breast reconstruction if they're going forward for a mastectomy. This can be in the order of breast reconstruction with an implant, or with a tummy, or with a tissue. So a tummy tuck style surgery whereby we remove the abdomen, we bring the abdomen up, and we make a new breast for the patient by placing it underneath the skin envelope. And then some patients may opt for a flat or a simple mastectomy. As I said, some patients that have ER, PR positive cancers will get offered chemotherapy after the surgery. In general, all patients with triple negative breast cancers, as in cancers that don't have an ER, PR positivity, will be offered chemotherapy, and usually all HER2 positive cancers will be offered chemotherapy. Chemotherapy will then be given, and then patients who keep their breast, have breast conserving surgery, will usually be offered some radiotherapy, which normally happens for 3 weeks and 1 day, so 16 sessions, 15 minutes a day. Like an X-ray style treatment to the breast, ladies that work will often continue to work during that time. And then for women that have had mastectomy, some of those will be offered post-mastectomy radiotherapy if they've had very big cancers, so more than 5 centimetres, or if they've had node positive cancers. Normally in this circumstance, I do usually talk to you about how to do a breast exam, but obviously I don't have a model at the moment. I think the tips I would say is, rather than sort of madly palpating your breast every month, I would say know what is normal for you. So make sure you're looking at your breast in a well-lit room. If it's not your bathroom, doesn't matter. Just make it a very well-lit, naturally lit room with a mirror, and make sure you clear your hair or derobe from your collarbone or clavicle to the inframammary region. There is breast tissue which extends from your collarbone all the way down to the inframammary region, and so you need to make sure that you include that area in your examination. Put your hands on your hips and look at your breast. Look at the contour, shape, size of the breast. Elevate your arms and make sure there's no tethering or pulling of the skin and the like. Have a look at the nipple. What does your nipple look like? Is there a rash on the nipple? Is there a discharge? In regards to discharge, look for a danger discharge. A danger discharge is a single duct spontaneous discharge. Multiple duct discharge that comes out when you're squeezing the nipples is usually discharge that is physiological. I mean, if you squeeze any nipple or gland, you're likely to get a discharge. That's not the discharge I'm worried about. Bloody discharge I am worried about, but I'm also worried about clear single duct discharge. Then you palpate the breast or feel the breast. You do it in a sort of clockwise pattern usually, or you can do it sort of up and down with the flat of the hands, and always going around the breast and then over the nipple and areola. You also feel underneath the armpit, and you should do that with the arm floppy by your side so you can get high up into your armpit. You might want to try and do that now, just so you get an idea of what I'm talking about. If you put your arm out straight like that, you can't get up high into the armpit. So you make your arm go really floppy, rest it by your side, and put your hand up high into your armpit. You're feeling for nodules, you're feeling for lumps in the armpit. Now, in thin women, you'll often feel, you'll often feel lumps. I mean, you feel lymph glands in a thin woman. But, what you're wanting to know is what's normal for you. And if you're menstruating, what's normal for you throughout the month. I mean, I meet a patient and they'll say, oh, that increased density or that nodularity, Chantel, in the upper outer quadrants is quite normal for me. I've always had dense tissue in the upper outer quadrants. It's totally normal for you to have that. And if that's your normal, that's perfectly fine. We know that there is more tissue in the upper outer quadrants of the breast. It is elastic envelope when your breast goes soft and saggy and south, if you like, in a postmenopausal lady. That can happen. And you're left with that sort of density in the upper outer quadrant. But we also know that breast cancer is more common in the upper outer quadrant of the breast. Talking about breast density and knowing how dense your breasts are, when you get a mammogram report, it should tell you are C, D, A or B. D is, the worst. It's very, very dense. A is very, very soft, very, very see-through. Just because you are postmenopausal does not mean you will have soft A-type breasts. And you can't determine necessarily breast density by looking at a breast or feeling a breast. You need to look at the mammogram to know your breast density. So if you don't know, find out. Ask your doctor if you've had a private mammogram. Depending on where you live and you go through breast screen will not always do 3D imaging. They won't always do mammogram with tomosynthesis. So you have to ask them. If they don't do 3D imaging, you're just getting an old-fashioned digital imaging. It's not very great for seeing detail. So you should go and get private imaging in that circumstance to get a 3D image. I think it is important for women to be their own breast friends, or best breast and best friends, in that taking sort of ownership of your breasts, knowing what your breasts feel like throughout the cycle, knowing who the breasts are, what they look like, and also making sure that you're your own advocate. If you're not happy with the decision someone's made, that you seek a second opinion, that you go elsewhere. And I think that it will then help you understand, is it normal for me? Do I need a biopsy? If you've got a solid lump in the breast, you need to get a biopsy of it to confirm that it's definitely not cancer. I think that would be an important tip from my perspective. Knowing that most breast cancers, however, are asymptomatic, that will be found on imaging alone with absolutely no symptoms. Even people with metastatic breast cancer may have no symptoms. If you're over the age of 40, get a mammogram. And some breast cancers are lumps with normal breast imaging. So I think that's probably all I'd like to say thus far, and I'm very welcome to take questions. And the other thing I should say, when you go home tonight or tomorrow and you look at your breasts and you look at them in the mirror, work out which one is bigger, which one is smaller. Asymmetry, you can see on my wall in my office, is totally normal, but you need to know what's normal for you.
Wow, amazing. Thank you, Chantel. So informative. I'm just wondering, are you seeing more? I think Sheridan mentioned today that you had quite a young patient come in with breast cancer. Are you seeing more and more young people, or you haven't noticed a pattern?
No, definitely. Yeah, 100%. More and more young people. The rate in the under 40s has gone up in the about 15% increase in the last 4 to 5 years in women under the age of 40. Certainly in our practice, the majority of our patients are under the age of 50.
Wow. Yeah, that's a lot.
Yeah.
As you said, great outcomes, I guess, and early diagnosis. I was saying to the ladies before you were here that that your policy, or your aim, is to see people within, is it 24 hours of diagnosis, which is an extraordinary undertaking. It's beautiful.
Yeah, and I mean, that's not really because there's any difference in overall survival doing that. It's more that most women just need a plan. And there's often quite a few other investigations that need to be done at a diagnosis to get, everything sorted for the patient. And so if you can see them, give the patient the plan and then get all that stuff done, it kind of takes a little bit of the pressure off, because people just need to know what's going on. They need a plan. They need to get the investigations done, so then we can proceed to the next part of their treatment.
And I think alleviating a lot of stress and anxiety straight up is probably super, super helpful to see.
Yeah. Yes.
And what would you say about, say, relationships? Do you see a pattern with women that get diagnosed that there's sort of two paths? It's either their partner is incredibly supportive, or perhaps just goes the other way somewhat?
Yeah, I mean, it was funny. I was talking to a couple of patients about that today, actually, because by and large recently, because I am seeing a lot of young ladies, we're getting a lot of really great sort of girl power. So even if they have got partners, they're bringing their friends to the consults with them. And these young women are extraordinary in that they're like doing all these fun things. Like they'll be in my waiting room and they're doing like a mini movie about how the Zippo tap works, and lining up the bottles in the waiting room and doing sort of videos of the fan going in a weird direction, and like just creating some humor for the patient, which I don't think men do as well as women do. And so for me recently, I've had a lot of young ladies come in, they're sort of late 30s, early 40s. They're bringing 2, 3, 4 support girlfriends with them that are coming with them to chemo. They're coming to see me, and then they'll go for lunch afterwards or something. So I think that is important. I think men have 2 ways that they generally go. They're either very, very supportive, or they're very angry and very upset that this has happened, and they don't know how to support their loved one or their person. They just drop the ball. And that can be very confronting. because there's no time to be dropping the ball in this circumstance. Like, it's just, you've got to move on. You just got to mentally try and get through. And we've got a psychologist in the rooms that's available to help both parties. It's not generally taken up. The men usually don't see the psychologist, but I think it is extraordinary. Women harness incredible courage and power at this stage, and they go through some of the darkest and toughest times of their lives, and they probably learn quite a lot about themselves and quite a lot about their relationship that they might never have known before.
Yeah, we have a sort of a theme that is really important at Community Women and Leatherback, which is community. And we've just noticed on our trips, it's like the bonds that get formed between women, as you say, with these young girls that are bringing all their girlfriends along. But it's, as you say, it's really, really powerful. I think that having a team of women around you, and some of our older women that are hiking with us have discovered that friendship is so strong, finding a like-minded group of people.
100%. And it's also women, I think, know more about the practical stuff as well. Like, you go to the room, they've bought nice pajamas, they've bought like a lovely cookies that they've baked, or some pear juice, or they've dropped off food for dinner. Like, they've offered to pick them up, they've taken them for a coffee after a concert. It's just like practical stuff as well, that really makes a difference that I don't think men even think about. They just have no idea about, would the woman need their washing done or something like that, Yeah.
And perhaps it might be generational, that maybe the younger men will have a little bit more, a different role perhaps they're playing in a relationship.
Yes, I suppose I am generalising, but yes, yeah, I agree.
Has anyone else got any questions for Chantel while she's here? She probably wants to rush home to her little man. So Thornton's broken his arm, has he? Did you say?
Yes.
Oh, I'm so sorry.
Fell off the the ladder that climbs up to the play equipment. It's a pretty nasty supracondylar fracture through the great growth plate and snapped through the whole bone and pushed forward, and the blood vessel was being compromised, so he had to go for emergency surgery. Yeah, so he was in a lot of pain over the weekend, so I've been doing 3-4 hour wake ups to give him analgesics, and I thought, oh my goodness, imagine being my age and being on call again. I'm lucky that, touch wood, usually the breast cancer patients, we don't get called in the middle of the night many times, and I thought, gosh, I don't think I'd be coping with being on call again. So I have to take my hat off to all those obstetricians and other surgeons that are doing a lot of call. Someone's raised their hand.
Elise, please go for it.
Oh, hi. Yeah, thanks for that. Yeah, it was very informative. So I'm in Queensland, and I'm just looking on our breast screen. I don't think we do the density reporting or the 3D imaging.
Yeah. No, I don't think you do either, Elise.
So that'd be talking to the GP, getting referrals to get them done?
Yeah. You're right, Elise. The thing about Breastscreen Victoria is they have started to pick up their game, but what they've done now is they've said, dear Elise, we just want to let you know that you've got category C breasts. Speak to your GP, full stop. So a lot of patients are like, oh, that's very nice. Yeah. And they put it in like a filing cabinet.
Yeah.
Then sees that, doesn't know what to do, no idea. So then they're overloading the breast clinics because, we've got 250 patients waiting for recall because they now don't know what to do. So it's all very nice of them to say you've got category C breasts, but there's no guidelines.
Yeah, okay.
Where 3D imaging should do that, which is sort of like, it's not great medicine. But what I can say is Breastscreen Victoria are actually doing a study at the current time, and they're actually getting AI involved in their scanning. So they're trying to work out if they can detect breast cancers earlier using the old-fashioned imaging, but subjecting it to an AI technology.
Yeah,
so they
can report on that. Yeah.
all of their scanners around Australia if they add on this special technology with AI. But I would suggest that you do go to your GP, that you pray for a private mammogram. Now, in some centres, you'll get a bulk billed mammogram anyway that will be a 3D mammogram, and they will tell you what your density is. And if it is A or B, you'd be okay to go through breast screen.
Okay, thank you.
And I know, like, whereabouts in Queensland are you?
Just in Brisbane.
Oh, yeah, Brisbane's okay. But I know in some parts of far north Queensland and the like, it's, you know, very even hard for them to get a mammogram. Or, you know, Ipswich and places like that. It's hard to get breast imaging.
Yeah. Yep. I believe it.
I have one more question. It probably applies to me, but what are your thoughts on coffee?
Coffee?
Hmm.
I love it. Actually, that's my cup that I still haven't finished from this morning. I mean, I don't think there is significant increased risk of breast cancer with caffeine. But what I can say is that it can sometimes increase the risk of, it can cause more pain with benign breast disease. Caffeine has been shown to increase the risk of inflammation associated with sort of fibrocystic change and can be associated with breast pain. So we usually recommend that people drink less coffee and have less chocolate. There is some preliminary studies looking at pancreatic cancer and the fact that pancreatic cancer can, might be a link between caffeine and pancreatic cancer.
Wow, thanks. And any supplements that you think that are good for women to take at certain ages? Or?
I think if you're deficient on it, vitamin D, there are some links with vitamin D and, you know, risk of breast cancer. Vitamin D is obviously a fat-soluble vitamin, so you can overdose on it. So I would recommend that you get your vitamin D checked, and that if you are deficient in vitamin D, that you take vitamin D, because low vitamin D is associated with a high risk of breast cancer. And then things like the vitamins A, D, E, and K are your fat-soluble vitamins. They're the ones that if you are deficient in them, giving it is good, but taking them without knowing if you are deficient can be dangerous. The other water-soluble vitamins, it does not appear to be a significant improvement in breast cancer numbers by taking them, and mostly people take those and they are creating expensive urine. Mostly, you know, people are taking a lot of them and they're just getting weed out. And I mean, there is a lot of longevity clinics and clinics looking at giving IV vitamins now. And I mean, they're expensive and you may not get more from them than you can just get from a very healthy diet. So I would use those sort of things with my eyes wide open.
And one last question, how do you do it all? Like, how do you factor in such a busy schedule when you don't really know who's going to turn up with a new diagnosis and children, and you can stay fit and healthy yourself?
I'm 20 minutes late for a talk, so I'm sorry about that. Yeah, I mean, look, I love to talk, as you know, so people are often waiting for me in my waiting room, which I feel bad about. But at the end of the day, sometimes you don't know. Like, the patient walks into the room and, you know, it's hot off the press. I get the results at the same time for the patient, and you can't kind of rush that patient through a 15-minute consult. You know, that patient needs time. So you do try and schedule them towards the end of the day. But sometimes you just don't know. So I think it's just, I guess from the patient's perspective, just being patient is what I would say, because, and most people know I'm going to give them a really good amount of time as well. And so they will get their problem addressed in the same way that someone else does. And I think that most people waiting in my waiting room will recognise when it feels quite tense. It's probably because there is a young person in the room with breast cancer, or a person with breast cancer, young or old, not to be ageist, because if you're 80 now, probably live another 20 years. And that it is a heavy day, and that they would normally say, thank God it's not me. I'm happy to just do a 10-minute consult because I don't have breast cancer, and you give the extra time to someone that needs it, you know. So I think women are very selfless by and large, and they can understand that, you know, it's hard to rush a patient that's been given a cancer diagnosis.
And your own self-care, managing, you know, so many balls in the air. Any secret sauce? You do run, I think, don't you? Maybe that's
Yeah, I think having a positive attitude at the end of the day, I mean, anything can look okay if you're not dying of cancer. I mean, it's not that bad. I'm not having chemotherapy. I'm not having my breast cut off. So I think that keeping your eye on the ball is important. And I just got a lot of helpers, Pip. I mean, every day I think, your phone's beeping, thinking, oh my God, who's not coming in today? And you've just got to breathe through it and just focus on what the most important thing is of the day. And the most important thing of my day is the operation on the day. There's a woman there that's relying on me and trusting me with their life, and it's the most hideous day of her life. So it's my responsibility to make sure that it's as easy as possible. And I've got a lot of great help. I've got, a live-in nanny now, first time in 5 years. I've got a husband that's reasonably flexible. I've got a lot of great friends, family members, people that help with school pickups. I've got a different nanny every day for pickup. I've got good staff, amazing team of women that, really care about patients and want to treat them the same way and feel invested in caring for women. And I think you've got to find a really great team, but, and with me, I'm very fortunate I'm healthy, but I do try to exercise. I still try to make that a real priority, trying to do something every day or every second day, even if it's only 20 minutes, just to get my headspace right and keep my body moving. And I think it is really important, exercise is really important. I think for me, it's what's got me through my very arduous training, my practice that's ever expanding, building my very long hours that I'm working, is that physical, emotional and psychological strength that I gain from exercise.
Yeah, and I think that's what made me just love the care that I got from you, was how empathetic and genuine you are, and that you just show up full of heart. I think that to me makes such a difference with any professional person, is that you can sense their care factor, and you've got so much of that, and it was really evident when I came to see you. So yeah, I think it's just a quality that's really, really necessary in the medical field, I think, but probably everywhere.
Yeah. Thank you. I mean, I think it is such a privilege to be a surgeon and to operate on someone. I mean, I think it's probably the most personal thing that you can do to someone. And so you do have to take that very seriously. Not to say that it isn't also scary sometimes for the surgeon as well. Sometimes I think, oh, gee, I wish I was like working in fashion or something like that, because it would be a little bit less stressful. But there's nothing greater than being able to say, I've been able to fix this problem for you. And I mean, surgeons actually don't cure cancer. I mean, surgeons think they do. They don't. The oncologists are the ones that really cure cancer. But to be able to physically make a positive difference to someone's life every day, I mean, it's an incredible vocation. We're so lucky to be able to do that.
Do you have particular oncologists that you tend to sort of work with in conjunction, or is it kind of a patient's choice to go and?
Yeah, no, I mean, they can. If they've got someone that they know that they like, they certainly can. But we do have this multidisciplinary team meeting, and we know that when your cancer is discussed at an MDM, you do better. Your outcome and your survival is better. And so there's a Medicare rebatable number for that MDM. So what I would say, if you've been diagnosed with breast cancer, ask your surgeon, have I been discussed at an MDM? And then you've got the opinions of multiple surgeons, multiple, oncologists. And those, I tend to choose people within my MDM because I know they've seen the cancer, they've heard the story, they've seen the imaging, and I know that they are receptive, and I know how they operate. Like, I know that they'll be there if there's a complication. I know they answer their phone. I know they'll come in the middle of the night to see the patient. I know that they manage the patient as I would wish to be managed myself. And so I am fairly selective who I ask my patients to see, because at the end of the day, it is my reputation, and it is important to me that the patient gets a good outcome. It's also important from an immune perspective that the patient feels confident in their team. And so it doesn't look good if the patient goes elsewhere and gets a bad experience, because they need to feel that they're being looked after and they're getting the best care, and they've got access to the best treatment that we've got in Australia for breast cancer. And so I have 3 or 4 people that I work with, and then I'll kind of work out the patient, like what I think their personality is like, what I think will gel with them. And then I say, look, I think this person would work really well for you. I've spoken to them. I've made an appointment for you to see them like tomorrow. Would you go? Send me an SMS afterwards. Let me know how you went. If you gel with them, if you like them, great. If you don't, let's find someone else. Because at the end of the day, the patient needs to feel safe and secure, and that team is going to be there by their side, because they've got to work with them for a long time. So they need to feel confident. And so that's just generally how I run it.
Wow.
Plastic surgeon, same with the radiation oncologist, because I mean everyone's different. Some people gel, some don't, and I usually only select people that I would choose to look after my family or choose to look after me.
Yeah, and I mean the whole team that I met through you were extraordinary. So I think you've definitely got all of that going on.
I mean, good human beings are important as well. And the other thing I would say is that as a consumer or as a patient, it's great if things are going well and things are all smooth. But if you get the complication, if you're the one that gets a complication or you're one when something goes wrong, you need to know that the doctor you're chosen is going to be there by your side, and they're going to be helping you through it. And that you can talk to them, that you can get time with them, that you understand what they're saying. There's so many different parameters to the patient relationship now, and that paternalistic side of doctor, you do this, you do what I say. I mean, the world's changed now. People have got knowledge. People can go elsewhere. They don't need to see you. So it has to be a relationship where everyone is trusting and there's open disclosure with all parties.
Which I think it's like you would love the guy that owns our company. They have that approach to everything they do. It's just like leave the world better, and also just be, super transparent, super kind, super just understanding that people are traveling and spending a lot of hard-earned money on an adventure. It's like, do they trust us to provide what we undertook to provide, or to fix it if it didn't quite go right, or those sorts of things. It's like, are we still there and available to have conversations and everything?
Yes, 100%. Yeah.
Wow. Oh, thank you, Chantel. You've been an absolute darling to come and give us so much of your time. I'm sure you're busting to get home. And
can I just say one last thing too? If you do get breast cancer, just make sure if you are having the surgical discussion that you discuss where the incisions are going to be placed, based on where your tumour is, and that they get placed in the most cosmetically acceptable position that allows them to remove the tumour and get a good result for you. Because at the end of the day, it is likely that you will live a long time. And what you don't want is someone making a terrible incision on your breast where you've got to look at that incision every day, and that's going to remind you of that cancer. So, I would suggest that patients, make sure that they are understanding of where the incisions are going to be made, and they know what they're in for.
Yeah, that's a great suggestion too. Thank you very, very much.
Thanks, guys.
And we're very grateful that you.
Because I don't know how to do one on a computer.
Oh no, well I'll just I'll stop recording now. And these are the girls I work with: is Sophie and Shona, and Mandy, Farah, lots of the team here. So thank you, Chantel.
Thank you. Cheers, Pip. Lovely. Sorry I was late. Bye.
Bye.
Thank you. Bye-bye. Bye. I don't know how to log out now.